Hi, today we will be discussing about the classifications of the subtype of stroke. So now this has been taken from the Stroke Journal way back in January 1993. So now the etiology of ischemic stroke affects the prognosis, the outcome, and the management. And the trials of therapy for patients with acute stroke are influenced by the subtype of ischemic stroke. As we know that if it is a cardioembolic stroke, we need to anticoagulate. If it is a large vessel disease, then we may have to go in for an intervention. If the patient has got a vasculitis and we have a report in our hand or we have a suspect in our hand, then probably steroids might be useful for them. A system of categorization of subtypes of ischemic stroke, mainly based on etiology, has been developed for the trial of OG in acute stroke treatment, and that's called the TOAST classification. It was found from the TOAST study that mortality was higher among patients with large artery atherosclerotic lesions than among patients with lacunes. So again, the subtype classification helps us to prognostify. The recurrent strokes were also very common among patients with cardioembolic stroke than among stroke patients of other causes. So we know that if there's a patient with a valvular heart disease, rheumatic valvular heart disease, DCMP, then our level of threshold will also vary for these patients. We might want to have them at a closer follow-up to ensure that they are taking the medications properly, and probably also to have that other investigations, like if they are on anticoagulants, to have a PT and INR in place. The 1 month mortality after cardioembolic stroke is also higher than with strokes of other etiologies. Now, what is the TOAST classification? We have 5 subtypes of ischemic stroke. There's a large artery atherosclerosis, cardioembolic, small vessel occlusion, stroke of other determined etiology, and stroke of undetermined etiology, which consists of ABC, which is 2 or more causes identified. There's a negative evaluation or there's an incomplete evaluation, and we'll go and look into each subtype one by one. The classification has been based, now it is basically how do we classify and what are the tools that we need to classify them. One is a risk factor profile. Then we also go by the clinical features of the particular stroke. And then we take the neuroimaging, CT or the MRI, whichever is available in hand for us. Yet, clinical and brain imaging features overlap and are not specific for any particular subtype of ischemic stroke. A classification of subtypes was prepared using clinical features and the result of ancillary diagnostic tests. So now whatever we tend to classify goes under a possible and a probable category, depending upon the physician's certainty. And how is that? A probable diagnosis is made if the clinical features, the presentation, like the patient has got dense hemiplegia, a neuroimaging, which suggests that the patient has got a lacunar stroke, he has got a basal ganglionic infarct, and the results of other diagnostic studies that we come to know that he has got risk factors of hypertension and diabetes, are consistent with one stroke subtype, that is a lacunar stroke, that is a stroke subtype, small vessel ischemic, small vessel disease, that is TOAST classification 3, and we have ruled out other etiologies that we have seen, that is 2D echo is normal, he doesn't have a large vessel occlusion, his corresponding carotids are normal, then he goes into probable small vessel disease, that is the TOAST classification 3. A possible diagnosis is made when the clinical features and neuroimaging suggest a specific subtype, but other studies are not done. Like the patient came and had an MRI, he has a basal ganglionic lesion, he is hypertensive, and he comes to the outpatient, he refuses other, or for some reasons, he's not able to get his other tests done, like the carotid and vertebral Doppler and the 2D echo. Then, but from the clinical features that he has got a dense hemiplegia, and he has got a lacune, so most probably it falls under the small vessel disease and goes into, but we have to write down, he's got a possible small vessel TOAST 3 classification. Because many patients have a limited number of diagnostic tests, the probable and possible subcategorization allow the physician to make as precise a subgroup diagnosis as can be achieved. So you know that if you have written there a possible diagnosis that you are not sure because you have not done a carotid and vertebral Doppler, there's a possibility that the patient could have a large vessel occlusion, and then he can land up with another stroke if you have not done an intervention. Having said that, we cannot force anybody, so we would be only suggesting, but then we would also be knowing from the possible and probable diagnostic criteria which we have mentioned. The large artery atherosclerosis, the clinical and brain findings. Now we come to the first one, where the clinical and brain findings, imaging findings of either significant, which is considered as more than 50% stenosis, or occlusion of a major branch artery or branch cortical artery, presumably due to atherosclerosis, right? So we have as the name suggests, there is an atherosclerosis which is significant, more than 50%. And he also has clinical features which are characteristic of a cerebral cortical impairment, that is aphasia, neglect, restricted motor involvement, that is a hemiplegia, or he has a brainstem or a cerebellar dysfunction. A history of intermittent claudication, TIAs in the same vascular territory, a carotid bruise, or a diminished pulses, which should be always checked for patients, especially the pulses of all four limbs should be especially checked to know whether he has any atherosclerosis. So the clinical features, the radiology diagnosis, either it is an extracranial and intracranial more than 50% stenosis. Now, the characteristic feature of the MRI also, or the CT scan should also be considered, in which the infarct size, whether it is cortical, brainstem, subcortical, cerebellar, it should be greater than 1.5 centimeter to be designated as a large artery atherosclerosis on a CT or an MRI. Supportive evidence, again, by duplex imaging or arteriography of stenosis, more than 50% of an appropriate intracranial or extracranial artery is needed. If the patient is having a left MCA infarct, but then he is having a vertebral artery stenosis of 50%, probably it's not an appropriate one. But then he may fall into a category if he has got more than 1.5 centimeter infarct size, and he has got all the clinical features of a cortical stroke. He could fall into the possible large artery atherosclerosis. Then the diagnostic testing, as always for everybody, should exclude potential causes of cardioembolic. I would come to that, why we need to. We have already found there's a 50% stenosis. We have already found that there is a 1.5. These clinical features are already matching. Is there a need for me to chase for a 2D echo or a cardiogenic cause? Yes, because any particular patient can have two sources of emboli, can have two causes of stroke, which we designate as TOAST 5 if they have one or two reasons for them to have a stroke. Now, the diagnosis of stroke secondary to large artery atherosclerosis cannot be made if duplex or arteriographic studies are normal or show only minimal changes. Now, let us look at cardioembolism and the arterial occlusion, presumably due to the embolus which arise in the heart and flow to the vessels of the brain. They are categorized as high risk and medium risk sources. The high risk are mechanical prosthetic valve, mitral valve repair, mitral valve or the aortic valve, mitral stenosis with atrial fibrillation other than the lone atrial fibrillation, the left atrial and the left appendage thrombus, the sick sinus syndrome, and a recent MI. So these ones, the left atrial, left appendage thrombus, needs a good technical support for a good 2D echo in the emergency department itself, because as we mentioned in the first few slides, the cardioembolic source have got recurrence, chances of high recurrence as well as a high mortality. Now, which one of the ones are medium risk with this mitral MVP, mitral annulus calcification, MS without atrial fibrillation, the left atrial turbulence, that is smoke, the left septal aneurysm, PFO. Again, needs good technical support from our cardiology technicians. Atrial fibrillation, lone atrial fibrillation, atrial flutter, sorry, not atrial fibrillation is high risk. Atrial flutter, a lone atrial fibrillation, bioprosthetic cardiac valve, non-bacterial thrombotic endocarditis, CCF, hypokinetic left ventricular segment, and myocardial infarction of more than 4 weeks. Having said that, sometimes these are all differentiating features of a high risk and a medium risk, but they can always cross boundaries and become high risk at any point of time. At least one cardiac source for an embolus should be identified, which has been enumerated in the previous slide. The clinical and brain imaging findings are similar to those described for LAA. That is more than 1.5 centimeter in any of the territories of the cortical, subcortical, brainstem, cerebella. Evidence of a previous TIA stroke in more than one vascular territory or systemic embolism supports a clinical diagnosis. For large artery stenosis, the TIA is in the single arterial. It would be a stereotyped TIAs. In a cardioembolic, it would be a non-stereotyped TIAs. So the patient could be having multiple symptoms. Sometimes he could be having a facial deviation, sometimes dysarthria, which could be there. A potential LAA source of thrombosis embolism should be eliminated, and a stroke in a patient with medium risk cardiac source of embolism and no other cause of, no other cause of stroke is classified as a possible cardioembolic stroke. Now come to the lacunar strokes, the small artery occlusion, whose should have one of the traditional classical risk factors, that is hypertension, diabetes, and should not have any evidence of a cerebral cortical dysfunction. In the earlier stages, when the patient has a basal ganglionic lesion, sometimes they do have aphasia, and then they tend to recover very well out of it. Then these infarct size are less than 1.5 centimeters. So large artery, cardioembolic more than 1.5, small artery less than 1.5. And then other cardiac sources of embolism and a large artery stenosis of greater than 50% in an ipsilateral territory should not be there. Rare causes of stroke. Now we come to the TOS classification 4, acute stroke of other determined etiology. Now here we are coming about from this hematological disorders, thrombophilia, sickle cell disease, hypercoagulable syndromes like the protein C, S, antithrombin 3, factor V Leiden, non-atherosclerotic vasculopathies, the vasculitis, the Takayasu's disease, angiopathies, RCVS, and that is a reversible vasoconstriction syndrome. All of these are designated under the acute stroke of other determined etiology. Determined, that we have to determine that they are there. Now, the clinical CT MRI findings are of an acute ischemic stroke, and there's no definition that it should be 1.5, more than 1.5, less than 1.5. And we should have the relevant blood tests, the vasculitic profile, the arteriography showing multiple stenosis suggestive of vasculitis should reveal one of these unusual causes of stroke. Cardiac source and the LAA should be excluded by other studies. Now comes the last one, the stroke of undetermined etiology. In several instances, the cause of a stroke cannot be determined with any degree of confidence. We couldn't find out. We had a 20% carotid stenosis, and there was a suggestion of atrial flutter going on there. And then the patient had a lecune. So we're not sure where to keep this patient. Some patients will have no likely etiology determined despite an extensive evaluation. Patient came 39-year-old. He underwent all the thrombophilic workup, the vasculitic workup, the TE, 2D echoes, arch of an MRI from the arch of aorta to the circle of Willis. Despite everything that we have done, which is possible and which could be possible in that particular patient, the results of the test come negative even after these extensive evaluation. Then they also come under stroke of undetermined etiology. We have not at this point. It was not. Maybe future we might find out some, but at that point, no. And in others, there was no causes found, but the evaluation was very cursory because we couldn't do the vasculitic workup, we couldn't do the thrombophilic workup. So still, we are feeling that these patients could be having these causes etiology. He's not a hypertensive, diabetic, non-smoker, non-alcoholic, young gentleman, doesn't have a history of injury to ruling out a carrot. So all of those have been done, but then we haven't done the whole load of investigation. So the evaluation was very cursory. Again, we need to keep him under stroke of undetermined etiology so that at a later point of time, probably whenever it is possible, we might be wanting to evaluate him further. The last one is a stroke of undetermined etiology, in which there is also when there are two or more potential causes. So one is evaluation has one the cannot be determined. We haven't been able to find out even after extensive evaluation. One is when the evaluation itself was cursory, and then the last one was when there are two or more potential causes of stroke, where we are now. As I said, there is a cardioembolic stroke, there's an atrial fibrillation in an elderly female of 75 years, and she also has a MRI features which is classical of more than 1.5 centimeter cortical strokes. And that is also for the cardio, that can also be due to the cardioembolic, but both are there and both are high risk cardioembolic and large artery. So we keep it under the category of undetermined etiology. Yes, so other examples should be having, that's what. So this already, and a traditional lacunar stroke with an ipsilateral carotid stenosis of 40-50%. So that comes. So we have the large artery stenosis, the cardioembolic, we have the small vessel disease, then we have other determined causes, vasculitis and others, and then we have the undetermined etiology. And that is it. Thank you. So I hope that this will help us to classify the patients better so that we can do justice to them so that they do not get a recurrent stroke. Thank you.